as members are trickling in, I'm just going to be speaking on some quick housekeeping um, and some events coming up. Um, First of all, we have a Palup side meeting coming up in April. I hope you join. If you can join in person, that is going to be in Angola. If you can join in person, I hope you're able to join online. And then the next in-person meeting for us in the North American group is going to be in Chicago during the AORTIC network reception in Chicago. And up till, I mean, we are open for suggestion if anyone thinks about things they want us to do, showcase or discuss. 2 years ago, what we talked about was collaboration and partnerships. Last year, we looked at our IoT grades and where they talked about, they were reflective on how biotic North America has come. So this year, during the Eric reception, it's going to be on a Saturday night. Open to suggestion on what we should discuss as a group. So that is in May, and then July 10 and 11, we are going to be having our Best of ASCO that is going to be holding in Abuja, July 10 and 11, right? So any suggestion as far as what is going to happen during the Best of ASCO, I'm open for suggestions, participation, and what have you. Please email me for your thoughts on this. All right. So now we are almost on 5 minutes of the hour, and I think that we have a lot to discuss. So again, I want to welcome everybody and thank you for joining this monthly session that we have been having. This is part 16 of Aortic North American series. And for this month of March and April, we are privileged to have a team from MassGen who are the celebrants for this month. And they are celebrating back to back. So they are going to be having this series this month and for the next. So this is being led by Dr. Akwe, my Zambian sister. She is an interventional gastroenterologist and also the director of global health programs in the gastroenterology at MassGen. She's an associate professor of medicine at Harvard Medical School. She's well known to everyone, and I especially admire her for her work with medical students. She is a pioneer for the POA group, and she's actually training the future of medical students, medical career, and shaping it. So the future of people, medical oncology or oncology as a whole in Africa literally is in our hands. So if anything goes wrong, we know who to this is the face of the person. But I know everything will go right, and I'm actually excited to see what she's doing. And she's doing great work with medical students. That is the highlight of it. So thank you for joining us. And I know that you're in the OR. That's where you say, I don't know why surgeons they dress all funny. Don't they have nice scrubs? I have that question. Can you guys wear nice crops? Like they always wear, like it's ridiculous. It's always the funny hats, the funny clothes, and everything. So she's in the OR. That is how dedicated she is. She's joining us today. Thank you so much, Dr. Akwe, for making this opportunity to be part of this team. And I know that we can't wait for the rest to start joining. They'll join in, and there's a recording anyways. So please go ahead and start the talk. Thank you again.
Thank you so much. Yeah, no pressure. The continent is in your hands. Got a big thank you, first of all, to Dr. Viola, and a big thank you to the AOTIC team. Very excited about this month and next month. Hopefully next month I won't be in this predicament. I'm not sure. I thought I had my schedule all sorted, and I did apologize to AOTIC once I figured out that I actually have procedures. It was just easier for me to stay in my scrubs. And I'm in the office. So if anyone's like listening from the government, I don't have a patient in front of me, but I do have to, I'll leave like halfway through because that's when I have a patient scheduled. So once again, my apologies. I'll be more formally dressed next time. But super excited about this month. It's Colorectal Cancer Awareness Month. And, you know, the quick statement is colorectal cancer is beatable, it's treatable, and it's preventable. And the challenge across the African continent is we do not have adequate screening programs for various reasons, which are not the focus of the discussion today. But it's something that we need to talk about a little bit more. And our speakers this month, we have three of the four speakers. Dr. Yeleki, Dr. Kazuma, and Dr. Odhiambo will be speaking today. And the approach for the presentation today was this multidisciplinary approach, because when we take care of patients, it's not one doctor. So we have a gastroenterologist, Dr. Yeleki, we have an oncologist, Dr. Odhiambo, and we have a surgeon, Dr. Kazuma, and they're all representing Dr. Odhiambo from the east, or Yeleki from the west, Dr. Kazuma from the south. And so the idea is just to try and understand how we approach these patients with colorectal cancer. Next month, we'll be focusing on esophageal cancer. And on that note, we've changed the schedule a little bit since we don't have our first speaker, but we'll start with Dr. Ganiat Oyeleki, who's, they're all dear friends of mine, actually, so I shouldn't even start lying. But she was the director of the WGO Training Center in Lagos, Nigeria, and she's currently a consultant gastroenterologist at Gastroderm. Dr. Diambo will introduce in Dr. Kazuma, who's the president of the Surgical Society in Zambia, and Dr. Diambo, who's one of the leading oncologists in Kenya. And I've had the honor of working with each and every single one of them for many years. So on that note, I'll hand over to Dr. Oyeleki, who will talk to us about screening of colorectal cancer, and then Dr. Odhiambo will then take over and focus on the oncologic approach, and we'll wrap up with Dr. Kazuma talking about the surgical approach. So over to you, Dr. Ileki, and once again, just a big, big thank you to AORTIC. I'm honored to be here today. It's truly a privilege, and I look forward to learning from all our speakers.
Thank you, Akwi. Can you hear me clearly?
Yes, thank you.
Okay, thank you. Thanks, everyone. Good morning. It's evening here. So nice to be here. And thanks for inviting me to be a speaker at this AORTIC North American medical webinar. And so my topic is colorectal cancer screening in Africa, and I'll do that in the next about 10 minutes. Yeah, so we know colorectal cancer is a major contributor to global cancer morbidity and mortality. And we also know that in the past, we thought, well, it's not really a problem for us in Africa. But we're seeing that we thought it was a disease of the high-income countries. And incidence we know is rapidly rising across Africa due to demographics and lifestyle transitions. The screening has substantially reduced CRC mortality, and we know, I mean, this cuts across even other cancers, but implementation in Africa remains rather limited. According to the GlobalCon 2022, about 1.9 million new CRC cases occur globally, and about 935,000 CRC deaths occur annually. It's the third most common diagnosed cancer. I think this is changing to even be at a higher level, and it's the second leading cause of cancer mortality worldwide. Mortality declines in the high-income countries, and the reason is majorly attributable to the presence of screening and early detection. So this is very, very vital. The burden of CRC in Africa is huge, and GlobalCon again estimated in 2022 that about approximately 70,000 new CRC cases annually, and approximately 46,000 deaths. And we know that this may even be so much more, likely because of underreporting. The projected increase by 2040 to 2050 could be driven by population growth. As you know, population is rapidly rising in Africa, increasing aging, urbanization, and dietary that is really westernized. So we're moving from our traditional African meal that is high in fiber to the so-called westernized diets, which is high in saturated, unsaturated fats and all the other lifestyle that could predispose as well. In terms of the stage at diagnosis, we know majority of patients in Africa present in the late stage. So we have people presenting in stage 3 or 4 disease. This also makes the survival to be significantly lower than in the high-income countries. And we know that the mortality to incidence ratio, which reflects the late detection, is also very, very high. And in some sub-Saharan countries, the survival in 5 years is majorly less than 30, which is the story in many of the sub-Saharan countries. People present late due to different challenges, both system challenges or even the personal patients themselves for various reasons. The rationale for screening now, so CRC we know develops via the adenoma carcinoma sequence. And we know that that takes about 10 to 15 years. So we need to make sure we detect these adenomas early before they become advanced. So the long preclinical phase provides the opportunity for us to detect the advanced adenoma much earlier, prevention of the progression by doing polypectomy. If we're able to pick the polyps early, then we remove the polyps. Then we're also able to downstage the invasive cancer by picking them much earlier. And there are several evidence supporting this. We have different studies showing that if we're able to detect early, then we can do something. The fecal occult blood testing for some people, which was the older methods of detecting, was able to reduce CRC by about 15 to 33% in some study. Use of flexible sigmoidoscopy reduces incidence and mortality. And the hallmark of the screening, which is the colonoscopy, is associated with 60 to 70% reduction in CRC mortality in observational studies. So it is recommended that patients or individuals, rather, from 45 to 50 years who have an average risk, they are recommended to have colorectal cancer screening to start to have the screening. I know this is done in the westernized and developed countries, but back home, this is still a struggle, and I'm going to discuss why. In Africa, the current screening landscape is not well organized. So we have very few organized population-based screening programs. And most of the screening programs are not the standard ones. So we do majorly opportunistic. So patient goes for other things and they take advantage and go ahead to do the screening, or maybe pilot initiatives. Some people are doing screening programs and all. So we do not have the large population-based screening programs in majority of the countries. Right now, we have the FIT, the fecal immunochemical test being done, but that is also not routinely done in many African countries. So they're still relying on the occult blood stool occult screening. I know that a study in Nigeria recently was a large study, was on the screening using FIT, and in some parts of North Africa and South Africa, Morocco, in South Africa, they've done that. But this is also not a reflection of what happens in most African countries. Even in Nigeria, it's only a pocket. I know in Ife, one was done in Lagos as well. So we still have the northern parts of the country, or the eastern parts, not benefiting from this. We do not have a continent-wide structured screening program. So this is also an area that we need to really look at to help with the screening. So what screening modalities do we have available? We have the FIT, like I said. The FIT is the low cost, it's non-invasive. It can be done either annually or once in in 6 months, which is twice a year. It requires colonoscopy to follow up. So if we do the FIT and it's positive, then you go ahead to do a colonoscopy. Colonoscopy, as we know, is a gold standard. It performs both the diagnostic and therapeutic option, and it has limited availability in most African countries for the reasons which we discussed. Either could be availability or even availability of the expertise and all that. Flexible sigmoidoscopy is less resource intensive, and it's what could be used in some centers as well. The cost effectiveness modeling suggests that FIT is the most feasible entry strategy, and this was based on the study which is quoted here in the low and medium income countries as well. So that's an area which we may have to put attention to. Do FIT first, and if FIT is positive, then you can go ahead and now do a colonoscopy where and when it's available. There are so many barriers to screening, and as we've identified a few, the major barriers could be include the health system barriers. We have severe shortage of trained endoscopists, as you know, even severe shortage of doctors in some parts of Africa. There's limited pathology services, weak referral systems. So sometimes the patients present at the remote areas and they're not able to get access to further diagnostic and screening methods available. The urban-rural inequities as well, so majority are in the rural areas, and everybody is trying to move to the urban area. There's congestion, there's inadequate support even in the urban centers. There's inadequate cancer registry. Not all countries have a dedicated cancer registry. So it's pretty difficult to even know the real incidence of cancer in this area. So those are things that would also affect the screening and planning. And in many countries, endoscopy capacity is insufficient even for patients that are symptomatic, not to talk of those without symptoms that are going for just the screening. Also, majority pay out of pocket. So this is the financial and policy barrier as well. So there's limited insurance coverage for preventive services, and there are other competing health priorities. So you have malaria that is there, you have other high blood pressure, diabetes, and so there are competing health priorities, and CRC is right not there where we want it to be. CRC is underrepresented in the national cancer control plans in most countries. There's some cancers are there yet, but I think we're not there with the colorectal. I know there's a lot of emphasis on the cervical and uterine cancer and all that. So we need to work on this as well. Sustainable financing mechanisms are critical for scale-up in most of the African countries. And the strategic implementation framework, which was a framework that the World Health Organization Cancer Control also aligned with, is a phased resource stratified approach and a pilot feed-based screening in defined age groups of 45 to 75, and it's aimed to strengthen colonoscopy's capacity, train endoscopy workforce, improve pathology turnaround, and strengthen population-based cancer registry. So we need to work on this and make sure this is feasible in most of the African countries to strengthen colonoscopy capacity by providing the equipment, increasing the workforce, train the endoscopists to be able to perform the procedure effectively, and put standards in place to make sure that even when you go for colonoscopy, you actually do what is meant to be done and improve pathology turnaround. So that's another area that we need to really improve. We do not have enough pathologies, and where they are available, they also require training and retraining, strengthening population-based cancer registries. Then we have to prioritize researches, and by doing this, it's local cost effectiveness, risk-adapted screening models. You can use different models to achieve this, capacity building interventions, and quality assurance framework and implementation science research. The evidence in this case must be tailored to African populations, and this is urgently needed. So this is we need to prioritize. We do not have proper documentation of the presence of, the incidences in most of the African countries. So rising and mortality remains disproportionately high. Screening is limited but feasible with this feed-based phased implementation approach. We need political commitments because it's something that may not be able to do. There are pockets of NGOs doing a lot, but this has to be done in a sustained and in a large way to actually make it more realizable. Workforce development is very, very important, and sustainable financing are very, very essential. People paying out of pocket would be challenging for them to do screening if they have to pay for screening and without any insurance. So we know early detectable is achievable, but it requires coordinated and evidence-based action. So this is the end of my presentation. I'd like to again thank you for inviting me to give this talk, and I hope I've delivered as much as I can. Thank you very much. Have a good day. These are my references. Thank you.
Thank you. Yeah, no, that was phenomenal. Our next speaker is Dr. Andrew Adhiambo, who's a consultant oncologist in Kenya. And he will be talking about chemotherapy, the simple questions of who gets what, when, and why. It sounds like a simple question, but it takes a little bit more depth. And of course, we just gave him 10 minutes to talk about all of oncology and making a decision. So I will hand over to Dr. Adhiambo, and then Dr. Aviola would kindly take over for me at this point. Thank you very much.
Thanks, Akwi. I hope everybody can hear me. My internet is a bit shaky.
Yes, we can hear you. Thank you.
Okay, so thank you, AORTIC. Thank you for the organizers. My name is Andrew Adhiambo. I'm a medical oncologist from Nairobi, Kenya, and I specialize mainly in GI and hepatobiliary oncology. And I'll take the next 9.5 minutes just to take you through the decision-making process in patients with colorectal cancer in terms of who gets what, when, and why. So that's the title of my talk. So let me start off with a real case. I've used a pseudonym. So let's call him James. He's currently 54 years old. He's been living with metastatic colorectal cancer for nearly 4 years now. He is known to be RAS wild type after we did his biomarker testing and mutation profiling. And he had a left-sided primary tumor which had been removed much earlier. He initially started on FOLFOX and cetuximab, which is an anti-EGFR monoclonal antibody that we use for RAS wild-type malignancies, and he's since transitioned into FOLFIRI, cetuximab, and most recently he's on cetuximab and low-dose 5-FU, and he's been on this therapy intermittently for almost 4 years now, with durable disease control, very good quality of life. He's working nearly full time. He takes care of his children. He still has a young family. So ask yourself, what made the difference? Was it luck or was it biology? And James is really not an outlier. He is what happens when we ask the right questions during someone's diagnosis. So this has already been said. The epidemiologic reality of colon cancer is that it's rising. There are shocking statistics now coming out of the US in that this cancer is the #1 killer in many young adults over the age of 50. And I believe Africa, we are yet to follow suit. And I think it's time we end the era of one size chemotherapy fits all. And now we have a molecular roadmap and we are obligated to use it. Traditionally, all patients with stage 4 or even stage 3 colon cancer, they just get chemotherapy for those who need it. And with that approach alone, patient survival is usually 12, 15 months, maybe 20 months. But with the addition of novel agents, targeted therapies, immunotherapy, and so on, we can improve this survival to up to 35 to 40 months using the latest statistics. So the decision tree is interesting because currently the NCCN and ESMO guidelines clearly state that for patients with especially advanced colorectal cancer, the staging is not complete without molecular profiling. Think of it in the era of breast cancer, for example. There was a time when ER, PR, and HER2 testing was only for the rich, and right now it's almost ubiquitous, and almost every patient, even in many sub-Saharan countries, would not be treated effectively without estrogen projection and HER2 testing. And I think we're heading in the same direction for colon cancer. We might think that these tests are fancy and they're only for those who are well-to-do, but within a very short time, these tests are going to become cheaper, readily available, just like HER2 testing for breast cancer. And we're going to be performing all these biomarkers in our patients, and especially those with stage 4 disease. So it's actually now mandatory to test patients for RAS, both KRAS, NRAS, BRAF, MSI, HER2, NTRK, among others, and at least for the stage 2 and 3 patients, knowing their MSI status and whether they have deficient MMR or they have POL mutations can help us determine what type of treatment they get. So stage 2 patients, and I know most of you get these patients in your MDT, the T3N0s and the T4N0s, those who are patients who we are deciding, will they get chemo or not? And in this stage of patients, doing the MSI status, and those who are MSI high generally have a better prognosis. And therefore, these patients do not benefit from adjuvant chemotherapy, whereas those who are MSI low, especially if they have intermediate risk factors for stage 2, then may benefit from 5-FU or capecitabine chemotherapy. So the question to ask yourselves is, are we treating our stage 2 patients are we over-treating our stage 2 patients in our institutions? When you look at those who are stage 3, and I think this treatment landscape has evolved over the last decade, and now we know that there's low risk stage 3 and there's high risk stage 3. So those who are low risk are patients who can be pre-selected to get 3 months of treatment instead of 6, provided you use capecitabine and oxaliplatin. So these are your Ts 1 to 3 and 1. So tumors that are not so invasive with 1 to 3 lymph nodes involved, and they have no other high-risk features, can be considered for a shorter duration of adjuvant chemotherapy. However, majority of the T4 N2s and the high-risk stage 3s would still get a full 6 months of Capox or Xelox. And now we are shifting more to an immunotherapy-based era, and there's new data that came out of the ASCO last year from the ATOMIC study where atezolizumab was added to standard chemotherapy for MSI high stage 3 patients, and there was a significant improvement in disease-free survival and overall survival. So it's time to really think about how to add immunotherapy to these patients. Approximately only 1 to 3% of colorectal cancer patients, especially in the metastatic setting, are MSI high. But it doesn't mean that we shouldn't look for it, because in those who have it, then their survival is significantly improved with the addition of immunotherapy, which is now a standard of care even for stage 3 patients in the adjuvant setting. How about in the stage 4 setting? As I've already said, testing for these biomarkers is actually mandatory. We should know our KRAS and RAS status, and those who are wild type benefit from anti-EGFR. MSI high patients benefit from pembrolizumab. Patients with NTRK fusions benefit from larotrectinib and entrectinib. The BRAF patients, we know the data from the Beacon study, where encorafenib and cetuximab gave a better survival. Those who are HER2 amplified, we know can use dual or single anti-HER2 therapy, and new emerging biomarker called POL or POL1 mutated patients have a quite considerable higher and more effective response to immunotherapy. Again, another issue is whether it's the left side or right. And from historical data, we know that left-sided patients benefit more from anti-EGFR patients, whereas right-sided patients benefit more from bevacizumab-based regimens. So that's something also to keep in mind in your MDTs. And the question to ask is whether sidedness is part of your MDT discussions. So that's just another small reminder. So the tumor will tell you if you ask it. So James, our patient, who is nearly 4 years on, is alive because somebody asked the right questions. What is the biology of the tumor? Staging alone tells you where. Molecular profiling tells you how. Precision therapy defines who gets what and why. And I think that's the era which we need to be getting into. So what do we owe every patient with colorectal cancer? We owe them to test early. If these patients can be able to afford this treatment, we better test them early. We need to discuss together in the MDT with the oncologist, with the radiologist, with the pathologist, and discuss which therapy is suitable for them. And we have to start treating the biology instead of treating the disease on its own. And understanding this biomarker and knowing which direction to go is usually the best way forward. So the question for Africa really is, the question is no longer whether we can personalize cancer care in Africa, but the question is whether we are willing to do it. I hope I've not gone over time. Those are my references, and sorry for moving very quickly, but I think I've given you the gist of the story. Is that right now it's more of a biomarker-driven landscape, and we need to select our treatment tailored to the patient. Thank you very much.
Thank you very much for having us for this wonderful presentation. And I believe we have one more presenter. Is Dr. Sik on? Oh, okay, perfect. All right. So I'm going to be welcoming him to, the title of his talk is The Surgical Approach. Who is a candidate and what is the approach? Thank you very much for joining us, Dr. Sik Kazuma.
Thank you. Can you hear me?
Yes, we can.
All right, all right. I think I've already been introduced, and this is the outline of the presentation. So most of this information has already been given. Just to say that in Africa, colorectal cancer is ranked 5th, and in Zambia, it is ranked 8th. Again, this is information from our cancer diseases hospital registry that maps the country with the incidence of cancer. Just to say that majority of the patients actually present late, either stage 3, stage 4 disease, and we see more of rectal than colon. And I think these reasons have been given for delayed diagnosis, such as limited screening capacity on the health workers, including the capacity of the facilities, as well as low awareness levels for the patients, and some traditional practices where they prefer traditional medicine to Western medicine. So surgical management, as highlighted earlier, requires multidisciplinary teams. The problem is the availability of the expertise in those teams. So you find that surgical, medical, radiation oncologists, together with radiologists, are sparse in their distribution, mainly in Lusaka and in Ndola. So MDTs are difficult to organize. So the others have to join in online to join the ones that are established. And the MDT will actually decide which patient is managed with curative intent and who is managed with palliative intent. And the surgical approach is either upfront surgery or borderline tumors are given neoadjuvant therapy to be followed by to be followed by surgery. So the problem of a surgical oncologist is to decide who I'm going to operate. So I think this has mainly been talked about staging and all that. The MDT is going to prescribe either a 2-modality treatment for colon cancer or a 3-modality treatment for rectal cancer, which is of interest to us in surgical oncology, to know who is resectable and who is borderline resectable, requires neoadjuvant to become resectable. Including palliative resections, even though there may be metastatic disease, but if they have obstruction or bleeding, this may be an indication for surgical resection. So our principle of oncologic resections for the colon or for these tumors is to aim for en bloc resection and segmental colic resection for the colon, aiming to harvest at least 12 lymph nodes and applying D3 lymphadenectomy, which allows us to get to the base of the segmental vessels that supply this part of the colon which has cancer, and also aiming for a proximal and distal microscopic tropically negative resection margin in the absence of frozen section, because in our facilities, we don't have frozen section. So we need to rely on the resection distance. For the rectal cancer in particular, we apply the total mesorectal excision as a standard and also aim for a negative circumferential resection margin. So the mesocolic excision is a very good technique. Comes in handy for surgical oncologists to harvest maximum number of nodes. So it's a medial to lateral approach. It allows radical lymphadenectomy and also allows total mesocolic excision. This is standard care. It allows the ligation of the feeding vessels from the pedicle and can be applied whether you're doing right hemicolectomy, left hemicolectomy, sigmoidectomy, or extended hemicolectomies. The important thing about this one is that you have erythroperitoneal dissection of the vessel that allow you to get the principal node. And the principal node importance is it can give you indication of what is M1 disease and what is not. For the rectum, the only difference in the rectum is the discussion of the distal resection margin. Where frozen section is available, you can apply a distal resection margin of 0.5 centimeters, but in the absence of the frozen section, then you'll be going around 1.5 centimeter as your distal resection margin. And the next discussion for the rectum is also what resections, when you apply because you know that if you do a sphincter resection, your patient then ends up with a permanent colostomy, and it's got psychological and social problems on the patient. And you know that if the tumor has involved the levator animaso or the external sphincter, then no sphincter preservation can be applied. Sphincter resection has to be done. So if you talk about sphincter preserving procedures, so you have two based on the distal resection margin. So you know that your low anterior resection can allow you to go as far as 2 centimeters. And then your intersphincteric resection can allow you to go as low as 0.5 centimeter. Intersphincteric resection, you do a straight colon anal anastomosis. This is hands-on, but for a low anterior resection, you do a colorectal anastomosis, usually stapled if you want to go as low as possible. The next discussion is the sphincter resecting procedures. These usually when the levator ani is involved and the external sphincter is involved, and also if the tumor is extended in the ischiorectal fossa. If the tumor is just involving the sphincters, you can apply the ordinary abdominal perineal resection, APR, and this follows the Goodsall's rule of going about 3 centimeters from the anal verge, and you'll be able to resect the tumor as a cylindrical resection without any wasting in your resection. But if the ischiorectal fossa is involved, and the entire levator ani is involved, you need to go a bit more wider in your resection, and you need to remove the entire ischiorectal fat. And this is going to be called now extralevator abdominal perineal excision. So once the abdominal perineal excision is done, we end up with big perineal defects like that one. But there is a technique that an oncology surgeon should do in the absence of a plastic surgeon, and this is an advancement flap, VY faciocutaneous gluteal advancement flap that allows you to close the defect, prevent perineal hernia formation, prevent herniation of small bowel into the pelvis that can then give you adhesion obstruction or development of just perineal hernia, which is unsightly. So we've just briefly discussed, hopefully I haven't rushed and lost people, but we've just briefly discussed to whom and using what are you going to apply oncologic resection that gives you microscopic negative margins, and you need to aim to harvest minimum 12 nodes. And if minimally invasive procedures are available, like laparoscopic or robotic surgery, studies show that their outcomes are not, long-term outcomes are not different from open procedures. And where expertise is available, then synchronous metastasis to the liver and lung can be done if the patient is fit, and also if the remnant organ is able to give adequate function to the patient. So this was my brief presentation. I think I've tried to be within the 10 minutes. Thank you.
Thank you very much for that presentation. Actually, you're our last presenter, and we have Dr. Quiver. All right, go ahead.
Temporary. Yeah, so we're, can you hear me?
Yes, we can hear you.
So yeah, I think we're open for, questions. Granted, these presentations were short, definitely encouraging others to follow through on any other colorectal cancer related presentations, since the emphasis once again is just how early detection makes a big difference, not only in the patient's life, but in those around the patient when thinking of, risk factors for family members and potential options for prevention. So the floor is open for any questions. So you could either type your question in, or you could raise your hand. As we're waiting, I do have a quick question. I don't know if Dr. Yalek is still on. I'm not able to see everyone who's on. But can you highlight for Nigeria specifically, because you mentioned that, do you currently have a screening program in Nigeria? That'd be the first question.
Hello? Aki?
Yes.
Yeah, thanks. Yeah, thank you very much for the question, Akwi. So at the moment, we do not have a national screening program, I must say. So what we do is basically just in Nigeria. So what we do is like the opportunistic kind of screening, in which, I mean, for whoever comes, we talk about colon cancer, or have you had it done? You're 50, you should get it done. Or maybe for those that have family history, then of course we're following them up. So we don't have a nationwide screening program, I must say. We don't have that. So, and what we usually like, so people that would, maybe they did an annual general and they found that they either occult blood was positive or FIT was positive, then they come in to go ahead to do colonoscopy. Or if maybe there's been a family history of colon cancer, or they've had history of inflammatory bowel, or they've had, so those are the ones we see majority at the moment in Nigeria.
Thank you. And Dr. Diambo, are you still on?
Yes, I'm here.
Okay. Just another quick question for you. So I know the talk was mainly focused on chemotherapy, but could you maybe briefly highlight, in a patient who presents with you to you, when trying to decide if this is someone who's going to get chemotherapy or radiation therapy, how do you make that differentiation, and is that even an option? And when do you decide, what, this is palliative, we've quote unquote maximized what we can do, or giving them therapy might cause more harm than good? And that's, I think, 2 or 3 questions in one.
Thank you. So I'll start with the easy one for radiotherapy. So radiotherapy is in general restricted mostly to rectal cancers, and particularly the lower rectum, because it's been shown to be effective to reduce rates of local recurrence if a patient is on a curative pathway. For the rest of the colon, from the proximal rectum, sigmoid, and the rest of the descending transverse and ascending, generally radiotherapy is not considered part of the treatment in the curative setting. Those patients would have surgery and then followed by chemotherapy. In most cases, in the chemotherapy we use for stage 3 patients is to reduce the rates of systemic recurrence. Now, for patients who are in stage 4 disease, because that's when we need to really make some big choices, is you have to look at the patient's overall performance status. Is the patient fit? Does the patient have oligometastasis, or is it low volume metastasis, asymptomatic metastasis, or does the patient have high volume metastasis? If your liver is full of tumor, you have jaundice, elevated bilirubin, high gamma GT, massive pleural effusions, ECOG performance 3, someone who is even unable to stand up from a chair, that's not somebody who should be pumping chemotherapy into in the aim of trying to improve their survival. And that's why the MDT is important. You get to decide who gets what through the MDT. Especially for rectal cancer patients, it's not possible in this day and age to come up with a robust and accurate treatment plan in the absence of discussing this patient in the MDT, because there'll be input from the surgeon. Is the tumor low enough for an APR, or are you going to do an LAR, or are you going to do no surgery at all? Or is the patient going to have a permanent colostomy? Those are discussions that come up in the MDT. Is this patient at high risk for distant metastasis, or at high risk for local recurrence? Do they need radiotherapy? Is it short course? Is it long course? So there's a lot to discuss in those meetings. So in most cases, especially for rectal cancer patients and for patients with stage 4 disease, they need a lot of decision making in their plan. But for patients with non-rectal cancer who have had successful surgery, as the surgeons have said, you've harvested more than 12 nodes, and maybe 4 are positive, and it's a straightforward stage 3 low risk patient, then the guidelines are very clear that this patient needs 3 months of chemotherapy to improve their survival. I hope I've tried to answer most of your questions in the simplest way possible. Thank you.
Okay, so while Akwe is waiting, I think that there's a question on the chat that I just want to quickly address, and it's about the GUAIC test, that why are we not using it as a screening? So the GUAIC test is not so reliable to check precancerous lesion. And the reason is because it has a lot of interferences. So before you do the GUAIC, you have to stay off certain meals for a period. And also because it can't quietly differentiate blood from other sources. So if someone has hemorrhoids, for example, and is bleeding from hemorrhoid, then it will also show. So it has a low sensitivity, I must say. So it's not a reliable test to use for screening. So, I mean, in places where other like FIT, which is a better one, is not available, we still use it in some cases, but it's not something that we should rely on. I know I didn't mention this, but if for Nigerians also, I'm sure maybe it's in some African countries as well, people have blood in stool a lot, and in Nigeria they call it jedi, which is like pile, and most of them, they feel it's not such a big deal. It's maybe because I ate something that's reliable. So I think those are challenges that are making even detecting colon tumors early very tough. You know, there are some patient-related factors, either denial that, oh, it's just, I just have jedi, or I have just pile and it's not a big deal, or some other personal and traditional methods that they feel would help to solve that. So, yeah, so, okay, so I think there's another question is been documented about gut microbiome.
So,
okay.
A quick question before we get into that one, because I just want to quickly catch Dr. Seki Kazuma before he hops off. Can you just quickly, and then we'll get to those other questions that I see in there. Could you quickly, could you comment on when do you decide whether someone's going to get open surgery versus laparoscopic surgery for colorectal cancer treatment?
Thank you very much. Yep. Thank you very much for that question. First of all, apart from the very short-term benefits of minimally invasive surgery, the long-term outcome, like I mentioned earlier, is not different between between laparoscopic and open surgery. However, laparoscopic surgery has got benefit of, short hospital stay, minimal blood loss. And for the pelvis, it really gives good access as opposed to open surgery. So if the patient, if the skill is available, the equipment is available, and the patient is right, then you would want to offer them laparoscopic as opposed to open surgery. But in our case, it's not a problem of deciding whether to give or not to give. In the Zambian context, we just don't have laparoscopy available for oncologic resections. It has no other reasons for deciding that this I'm going to give, this one I'm not going to give. So availability and expertise are the main confounding factors. The patient factors very few, and you can navigate around them. I hope I've tried.
Thank you very much. And I think this next question in the chat is for Dr. Odhiambo.
Sorry, I'm sorry.
Yeah.
Can I take Professor Chris Williams has had his hand up and wanted to say something. Prof?
Oh,
Right.
okay. Yes,
Yeah.
please.
Thank you very much. Chris Williams, I'm speaking from the west coast of Canada. It's been actually very nice and listening to these three presentations from various parts of Africa. And listening, one can actually see that differential progress has been made on the continent of Africa. It's very stimulating to listen to what is happening in Nairobi, in Kenya, presented by Dr. Odhiambo. His presentation could have been made anywhere, like in Canada, showing the high level of care that is being provided for gastrointestinal cancer in Kenya. And also the presentation by Kazuma from Zambia, Undola, is also very impressive. I'm a little bit disappointed about the presentation from Nigeria. And I'm concerned that much of what is happening in Nigeria continues to be a manifestation of widespread health illiteracy, which is probably responsible for the practice of medical tourism, whereby highly placed politicians just desert the healthcare service of the country and go abroad for treatment, thereby leading to what Dr. Oyeleke describes as opportunistic approaches in the management of colorectal cancer. So, having said that, I really enjoyed these three presentations, but I'm disappointed that the majority population of Africa has not been addressed, and that is colorectal cancer below the age of 40. 80 to 85% of the African population is below the age of 45. So there's no point talking about the pilot fit program, which is directed to the 45 to 75-year age group. Less than 5% of Africans are of that age group. 85% are below the age of 45, and we haven't heard anything about the colorectal cancer management of that age group. So yes, this has been a very, the presentation has been very, very, brilliant, but the wrong age group is being addressed. And next time, hopefully, we'll be able to hear more about what is happening to young Africans having colorectal cancer. Thank you.
Thank you, sir. All right, Akwa, you can continue.
Yeah, no, I just want to add, I think so we don't put Nigeria on fire. So I think Dr. Oyeleke's presentation is a reflection of the continent and not necessarily in Nigeria. Nigeria is actually one of the most advanced when it comes to colorectal cancer research from a GI perspective. Some of the studies from Nigeria are what's leading the continent. And Nigeria is actually one of the few countries that is addressing the challenges of colorectal cancer screening. Most of the data we have published, and I've published from Zambia, does show that we have a young age of colorectal cancer screening, and Nigeria is one of the first few countries to start off by using FIT, and this was highlighted with Professor Alatishe Olusegun, who's done probably one of the strongest works in that arena. So I think the challenges of colorectal cancer in the continent, what we do know, it's in the young age, but what we're lacking is simply the data. And I think that's what we're all trying to provide. And I think this talk is sort of one of those that provides the knowledge of how we can contribute. And I would say that the challenges of medical tourism are very universal. My master's in bioethics thesis was on medical tourism in Zambia. So I think it's universal across the continent. But I think some of the messages shared today can definitely be applied across the continent, and not only for Nigeria, because definitely Nigeria is leading in that arena. And what Dr. Oyeleke was presenting sort of highlights some of that. We can probably take one or two. Oh, I know we're on time. We're tight on time, but there's a question in here. It says, has TNT approach for rectal cancer treatment been adopted in Africa, and what are the outcomes compared to conventional? I think this question is for Dr. Diambo, because I'd interpret TNT as total neoadjuvant therapy. So if you're able to address that question before we sign off.
So thanks again. I think the TNT approach is a wonderful strategy, particularly for the more advanced and lower rectal tumors. I think most MDTs that I attend across Kenya are pushing to and implement TNT in majority of patients. But it's important to note that TNT it's a team effort because everybody needs to be involved. Every player in every stage of the therapy is as important as the therapy itself, so that patients don't get lost during the way or don't get lost after radiotherapy or comply to their chemotherapy. But definitely the outcome is better with TNT for those who need TNT. For the very early and probably higher rectal tumors, some of them could be treated similar to the normal colon cancer without using a TNT approach. I think the world over, the exact sequence is evolving over time, and I think within a very short time, we'll have the exact sequence as to who to start with short course versus long course, who should have surgery and then chemotherapy or chemotherapy before surgery. But the whole basis of TNT is to do all your treatment and then do surgery last. And at least in my experience, in my center, we're having better outcomes with TNT, especially for the higher stage lower rectal tumors. Thank you.
Maybe we can wrap up with this last question, and then I'll hand to Dr. Abiola. So the last question is great discussions, and maybe each speaker could answer this. Could the speakers reflect on sustainable efforts for capacity building for colonoscopy and colorectal surgery and availability of equipment for scoping? How are different teams dealing with the stigma around stomas? Dr. Ilecki, Dr. Kazuma, and then Dr. Odhiambo, if you'd want to take this on.
Thank you, Akwi, for the moderation. And yeah, okay, so I was going to talk about what, I don't know, Dr. Williams mentioned earlier. So we have screening available in Nigeria. And as Akwi said, the tourism is not limited to Nigeria. However, we're seeing very young people presenting early, and we do not have a standard screening, population screening for the young ones. So that's the thing. But if patients with rectal bleeds or high index of suspicion or positive family history of colorectal cancer, we know that we screen them earlier. Of patients with IBD or some other medical conditions that require them to be screened earlier, they are screened. So in terms of sustaining capacity building, we are doing a lot. We have the Society for Gastroenterology and Hepatology in Nigeria, and we have courses to help to train endoscopists. We have different other panels or methods or avenues to train GI physicians and surgeons to do endoscopy. The challenges is at times, most times in the equipment, in terms of the provision and the maintenance of equipment, and there are different other groups that are helping to support that. So yeah, so that may be challenging, but we're finding a way around it, and we're hoping that things will get better. Thank you very much.
Thank you. Dr. Kazuma, and I'm not sure if Dr. Odhiambo is still on. The same question, please.
Yeah, very interesting question. The issue of capacity building has been highlighted in many studies, and is something that is very active in the African setting and also in the Zambian setting, to train more staff in various fields of oncology, because clearly the gap is massive and it's obvious. everyone has seen that this is a major problem. We have few centers that offer mentorship and training in endoscopy, but this is just mainly diagnostic, which aims at just scoping and getting a biopsy. So surgical endoscopy is something that is not yet developed. So we need to go to therapeutic uses of endoscopy. The issue of sustainability is where the problem is. Looks like we are a bit overwhelmed with the whole burden of the disease itself and trying to find where to put our feet. But I think the future looks bright. Thank you.
Thank you very much. So I think Dr. Odhiambo's off the call. At least I saw him fall off the call. So once again, I just want to say big thank you to AORTIC for this opportunity. And I'm looking forward to our April session, which will focus on esophageal cancer. I'll now hand things over to Dr. Abiola. So thank you very much.
All right, thank you very much for this wonderful presentation. We'll all agree that this is very mind-boggling, and we have a lot of questions here. I hope we'll carry over the questions for our next session in April. So we are just about, according to my African time here, we are just about 11:50. So we are about time. Thank you again for joining. Do we have any questions or any addition to this? Okay. So in the absence of, you want to say something? All right. So in the absence of no one saying anything, I just want to say thank you again. This is goodbye, and we'll meet again April 1st Tuesday of every month for the continuation of this discussion. Thank you very much. All right. Bye-bye.
Thank you very much.